when I was in my residency, I was still amazed at how ignorant we were as surgical residents of pain management. I mean, completely ignorant. There was absolutely no teaching of this subject matter. Something that I learned that was very simple was studies had demonstrated that before you do an incision on a patient, if you inject Marcaine, which is a long-acting sodium channel blocker, like like the type of, like a Novocaine type thing that the dentist would put in your teeth. So you have lidocaine, which is short-acting, Marcaine, which is long-acting. If you inject the incision site with Marcaine before you cut, you wait a moment, you then make the incision, and then immediately following surgery, you put the patient on a pretty aggressive dose of NSAIDs. Many patients can actually avoid narcotics postoperatively for the incisional pain, which is the dominant source of pain. Yeah. And I remember thinking, why aren't we doing this with every patient? And I got into an argument with one of the attendings because I was about to do an operation, and I went to do this, and he said, come on. That's going to take 5 minutes. You've got to, put that in, and then we have to sit here and wait 5 minutes with our dicks in our hands while it sets in before you cut. No, we don't have the time for that. And I remember thinking, really? We don't have 5 minutes? It was shocking.
Yeah. But listen, I mean, I think in a weird way, and I say I'm not a doctor, right? I say this coming from the outside, but having done a little bit of a kind of anthropological bushwhack through this world over the last few years. You go back to what we were talking about earlier, where you have the Sackler brothers in the 1940s and 50s saying, wouldn't it be beautiful if someday there was just a pill you could take for everything? And particularly Arthur Sackler kind of trying to sort of intermingle medicine and commerce in ways that I think ended up being more profound than anybody could have probably recognized at the time. From the outside, I think that one of the ingredients that gives you the opioid crisis is actually that idea of like, we want to waste 5 minutes. We need to get our patients in and out. Time is money, and there was I've interviewed doctors who talk about how they felt duped, how when the Purdue sales reps started flogging OxyContin, if you're a doctor, you encounter patients who are in pain, you want to relieve that pain. It's often it's kind of in some ways inherent to why you chose to do this in your life, right? Is you want to bring relief to people who are suffering, and suddenly there's this medical innovation which you're told is like a panacea. It can relieve that pain and has virtually no side effects, and people can take it forever, and there's no dosage ceiling, and so I've talked to people who've said just earnestly, that was a siren song I was all too ready to listen to because it filled a need in my kind of therapeutic arsenal. And of course, it ended up being more complicated. But I also think that when you think about the way in which American medicine is structured, the idea that you have a patient who's in pain and you say, I'm going to write you a prescription for 20 milligrams of OxyContin, be on your way. I never have to see you again. I'm not really going to give any thought to how this is working out for you 2 weeks from now or 2 months from now or 2 years from now. I think that that notion that, that 5 minutes is money, right? 5 minutes is that 5 minutes is 5 minutes you're not spending with the next patient. It's a longer line in the waiting room. I think those kinds of structural considerations were part of what allowed Purdue and other opioid makers to kind of snow the medical establishment as effectively as they did. Where if you look at the prescribing levels for these drugs, with the introduction of OxyContin, they just suddenly start climbing in this really dramatic way. And you would think that there would have been more skepticism, that it would have been slower growth. But I do think there was a sense in which it sort of it filled a number of needs, right? And that was what allowed it to take off the way it did.
Well, it also seemed to become very politically correct in the sense that they somehow managed to infiltrate the AMA. I mean, one of the other memories I have from, the early days of residency was how all of a sudden a new vital sign emerged. So vital signs are by definition objective. So they are things that can be measured for which there is no ambiguity. Temperature, pulse, respiratory rate, blood pressure. But then a fifth vital sign got introduced, which was pain, a subjective measurement on a scale of 1 to 10. And there were laminated posters on every corner of the hospital. Don't forget the fifth vital sign. Don't forget the fifth vital sign. What is the fifth vital sign? What is your patient's pain? I mean, it was, and this really came from the medical community. This was a form of self-policing. So how involved was Purdue in driving that agenda?
I mean, I want to be careful about how I put this. Very would be the short answer. But I think you have this tricky thing. It's a little bit like when I was talking about Curtis Wright and the FDA and how there's a kind of soft corruption that happens, which is it's not as glaring as the kind of caricaturish corruption that you would think of. I think there's a similar thing here where you have the American Medical Association, you have all kinds of groups, groups of doctors, groups representing patients' rights, kind of pain advocacy groups, and then you have industry underwriting a lot of this stuff. And there's just quite a good piece in Mother Jones just recently about the AMA and the Richard Sackler was on one of these boards, and you have a lot of money going to sponsor education.
Yeah, well, that's I just read that Mother Jones piece, and I couldn't believe that the AMA, both as an organization and its foundation, separately are receiving money from the Sacklers. This podcast is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and the materials linked to this podcast is at the user's own risk. The content on this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Finally, I take conflicts of interest very seriously. For all of my disclosures and the companies I invest in or advise, please visit peterattiamd.com/about, where I keep an up-to-date and active list of such companies.